Good afternoon, everyone. Welcome to another edition of Medical Grand Rounds, and this one will have a COVID focus. I think I probably threatened 2 or 3 months ago that we would stop doing these or slow them down, but that clearly was not the right call. And there is a tremendous amount of new information that we will explore today. A program note for all of you: will be off for Grand Rounds the next couple of weeks, and then we will return on January 6th with a talk by our UC presidential chair, Dr. Kamara Jones from Morehouse, in a joint medicine pediatrics Grand Rounds focused on health equity. Then on January 13th, we'll do another COVID update. I'm assuming there will be even newer information over the course of 3 or 4 weeks. And for that one, we'll have Eric Topol will be the main speaker. Eric, as people know, has been one of the most foremost commentators and analysts of what's going on and the evidence base with COVID. He is at the Scripps Clinic, and proudly, he's another former UCSF medicine resident who has made a splash. Today, we will focus on the rapidly evolving COVID landscape, particularly the fire hose of new data related to Omicron. The ground rules were just up there, just so you know. Closed caption is available. CME is available. Stay on at the end if you want CME credit. And if you have questions, please put them in the Q&A box. And Lakshmi Santosh is monitoring that, and we'll try to get to as many as we can. The first 20 minutes, we'll hear from Carlos Del Rio about what we have learned about Omicron in the last, I guess, 3 or 4 weeks. And after Carlos's lecture, we'll have a panel discussion with Carlos, Rachel Bystritsky, and Paul Sax about what it all means and what we should all be doing in response to this new and rapidly evolving threat. So quick introductions of our 3 speakers. Thank you all for joining us. Carlos Del Rio is Distinguished Professor of Medicine in the ID Division at Emory and Professor of Global Health and Epidemiology at the Rollins School of Public Health. He's also Executive Associate Dean for Emory at Grady Hospital, PI and co-director of the Emory Center for AIDS Research. And among his many titles, he is president or president-elect. Are you taking over yet, Carlos? You're on mute.
President-elect.
President-elect, okay, of the Infectious Disease Society of America, which is the major ID society in the country. He's co-authored 5 books, 30 book chapters, and over 500 scientific papers. And if I continue with his bio, he won't have time for his talk. So Carlos, we'll start with a brief talk, and then we will have a panel that brings on Rachel Bystritsky, who is Assistant Professor of Medicine in our ID division at UCSF. Rachel was resident and chief resident at Columbia. We were lucky enough to recruit her as an ID fellow, and she has joined our faculty. And since joining, she's taken on several leadership roles, including being medical director of our infectious disease clinic and our outpatient parenteral antimicrobial treatment program. So she serves as a key person dealing with all of the issues of COVID that confront a very busy ID clinic. So Rachel, thank you. And we also are really honored to have Paul Sax. Paul is clinical director of the Division of Infectious Disease at Brigham Women's Hospital, where he's been on the faculty since '92. He was a resident at the Brigham, did his ID fellowship at MGH, and then returned to the Brigham to take on a variety of leadership roles, including running the AIDS clinical trials unit there and associate program director of the Brigham MGH ID fellowship. And he's known far and wide as a go-to clinician in the field of infectious disease. And I'm guessing he spends 99% of his time on COVID these days. So looking forward to the discussion, but let's hand it off to Carlos to begin with an update on what we have learned about Omicron in the last few weeks.
Thank you, Bob, and thanks for the invite. I hope people can see my slides. We're going to be talking about Omicron and where we are with this new variant. So first of all, just remember that the COVID pandemic is not over. We are in a 4th wave right now, with about 82% of cases occurring right now in Europe. Europe is really where the pandemic is very, very active right now. And this is when Omicron surges. Omicron is the SARS-CoV-2 variant that was first detected in Botswana on November 11th, and then identified in South Africa 3 days later. It was detected November 13th in Hong Kong in a traveler returning from South Africa. The WHO labeled it a few days later, on November 26th, a variant of concern. And a total of 5,563 genomes from over 60 countries have been uploaded thus far. South Africa was able to detect this because they have a very good network of genomic surveillance in place. And what they noticed very rapidly is they noticed this line in blue which is this huge spike. When they were almost having no cases, you can see here, their positivity being very, very low, they started to have this rapid rise, this huge spike in cases that actually had an S gene or spike gene target failure. And this is sort of a good proxy for this variant and for this, and they noticed this very rapid increase. So test positivity rates started to go very rapidly up in Gauteng province, and you can see here they were having very low positivity rate in their testing, and all of a sudden they noticed this area with a greater than 30% positivity rate. And again, you can see that their cases were really coming down in almost everywhere, but they noticed this very slight increase in the number of cases in Gauteng province. And this was related initially to this outbreak among college students, were among college students that went on a field trip. They were all in a bus together, and many of them became infected, and they all had this mutation. As of December 15th, there has been detected in 80 countries, and it's spreading very rapidly in many European countries, as I said, including Denmark, Norway, and the UK, and has been identified so far in 36 US states. And you can see here how this moved very rapidly around the world, and how this line shows the way in this has disseminated across countries, to the point that today we have all these countries impacted, and this are the number of cases being reported, with the UK now leading the charge with over 10,000 cases, but Denmark was 6,000 behind, and you can see the other countries here and how the US is already as number 5. But you can see across Europe, when you look at the 3 countries, Denmark, the UK, and France, there's very rapid increase in cases in all of them, but yet not a huge spike in number of deaths, but it's beginning to go up in some of them, and something that we can talk about it later, and we can discuss during our session later. In the US, California, you were the ones, San Francisco, the ones to detect Omicron. And but of course, we all are against, or we should be against, travel bans, because they're really not evidence-based. And this cartoon shows very clearly what travel bans are. We close the door to Omicron, when in fact Omicron is already inside the house, and we didn't know it. So why is Omicron so concerning? Well, it has a lot of mutations that do 3 things. They've been associated with more efficient cell entry, they've been associated with immune evasion, and they've been associated with immune infectivity. But again, we don't know how this combination of mutation is going to work together, and what's going to happen when they all appear in one place. This is an unusually high number of mutations, 45 to 52 amino acid changes, deletions, or insertions, 15 of them in the receptor binding domain. And as I said, they've all been associated with different changes. But what really strikes you is how this variant Omicron is so different from other variants. It doesn't seem to have evolved over time, but it seems to have evolved from one beta strain. And this is why some people think that this evolved over time in one patient. And one of the theories that is not confirmed is this evolved by staying in somebody with advanced immune suppression, like somebody with HIV, that is unable to clear the virus, and therefore the virus is able to mutate and to evolve over time. And again, this is a theory, but it hasn't been confirmed. But this is a nice publication showing this in one individual, not this case, but another case. So is it more transmissible? The answer is yes, likely 2 to 3 times more transmissible than Delta, which is already highly transmissible. And again, I take you to the positivity rate that we saw before. Well, this is what it looks a few weeks later. I mean, you go 1 week later, and you essentially have a bunch of the province with having over 30% positivity rate. And you can see where we were and where we are now. This is December 15th, where they are in cases. In the UK, we're also seeing a rapid rise. You can see in green there how Omicron is going up very rapidly. And the doubling time is about 2.5 to 3 days, which is just incredibly fast for cases to go up. And that's why when somebody says, well, we have 3 cases today, well, think about 600 in 2.5 days, and we'll keep on going exponentially. That's why you almost have a straight line going up. Couple of outbreaks that are concerning. One is the so-called Christmas party in Oslo. 111 persons attended a Christmas party at a restaurant in Oslo on November 26th. I guess they celebrate Christmas early over there. Most were between 30 and 50 years old. All had been vaccinated. None had been boosted. 80 people, or 70%, were subsequently diagnosed with SARS-CoV-2, mostly of the Omicron variant. And more than 60 people who visited the restaurant the same evening were also confirmed infected. Everybody had to show a negative test 71 to 3 days before the party, and yet they were all, there was infection there. And you can see the symptoms: 70% having cough, lethargy, headache, sore throat, but nobody being hospitalized. The other outbreak, infection, which is interesting, is this one in Hong Kong, where two travelers were quarantined across each other in the hallway. They were confined to their rooms. They were not in contact with each other, and yet they both tested positive, and their genomes are very similar. And finally, there's data from household transmissions suggesting that the household setting Omicron, if it's infectivity is roughly 2 to 3 times higher than what it was in Delta. So does it cause more severe disease? And here we have no evidence yet that it causes more severe disease. But I'll caution you that the samples are small yet. Most patients are young, so we have to see. And you know, the reality is a lot of the cases are also in travelers, and travelers by definition are healthy. This is the data from South Africa. You can see hospitalization. You can see cases, daily cases in orange line. You can see hospitalizations in blue. And again, hospitalizations are starting to go up, but you can see ICU admissions are not up, and percent of hospitalized for an event are not up, and percent on the ICU are not up. So again, maybe some hospitalizations, and when you talk to colleagues in South Africa, they say, yeah, they get admitted for 2 or 3 days. They get discharged. Many of them are because we pick them up because we're doing routine testing and they were admitted for other reasons. In other words, they were not admitted for COVID, but they were admitted and then were found to have COVID on admission testing. Can it evade the immune system? And here the answer appears to be yes. And this is some data that I'll show you. If you look at neutralization, there's a lot of data here, but shows multiple vaccines, you know, the Chad-Ox vaccine, which is the AstraZeneca, the BNT162b2, which is the Pfizer vaccine. And you can see here in all of them, if you look to the very right, the B11529, which is the Omicron strain, you can say neutralization is almost gone to that strain in any of these vaccines or any of these individuals. Even in convalescent plasmas, there was some protection against some of the other strains. There's no protection here. But the good news, and I like the term, is a super immune individual. You know, if you previously had infection and then you get immunized, you receive a vaccination, you get a very good response and you get good protection. The data with Pfizer with 3 doses, again, shows after 2 doses, almost no protection against Omicron, 21 days after the 2nd dose, but 1 month after the 3rd dose, you have here an Omicron in pink, you have a very significant protection, maybe not as good as it was with the original strain, but comparable to what it was against Beta and a little less than it is against Delta. Summarizing the data, you know, we all heard about waning immunity to Delta after 2 doses. If 5 months have gone by and you fully vaccinated with Pfizer, about 60% protection. You get a booster shot, you can raise that to about 95% protection. Against Omicron, if you got 2 doses of Pfizer, you only have about 35% protection. Against this, against infection, not against severe disease. And if you boost yourself, you can get that to about 75% protection. So you do get an effect from the boosting. Similar data has now been reported from the NIH with the Moderna vaccine, seeing you know, essentially no efficacy against infection 2 weeks after the 2nd dose, but 2 weeks after a boosting, seeing a significant protection against not as good as the ancestral strain. In real world data, because that's all in the lab, in real world data in England, they're reporting that with Omicron, you essentially had no protection, but against infection. But after boosting, you can see 2 weeks after boosting, a drop in the number of infections with better protection. Past infection is not protective. You can see here in previous waves in South Africa, how they saw in each one of those waves, you know, if you were infected initially, you didn't really have much risk of infection. In your 2nd wave, after infection in the 1st wave, 3rd wave, same thing. But now you're having a reinfection rate go up, and that reinfection relative hazard is here, which is very similar to if you were not hadn't been vaccinated. So this summarizes the data. If you're vaccinated with 2 doses, you get boosted, you get a very nice response. If you've been infected before and you get 1 dose of vaccine, you get a very good response. So we need to get everybody who says, oh, I have natural immunity, I don't need to get protected, to at least get 1 dose of vaccine to get protected. And again, I like telling them that they will be super immune if they do that. Monoclonal antibodies don't look good at all. This is a lot of the monoclonal antibodies. The one you need to know of the ones available is sotrovimab, and that appears to have efficacy against the Omicron strain. All the others, whether you're talking about the Lilly monoclonal mixture or the Regeneron, they appear to have no effect. I haven't found data with the AC monoclonal, but that has been approved only for pre-exposure prophylaxis at this point. So summary, Decreased neutralization from vaccines and prior infection, expect the vaccines to remain effective against severe illness and death, and boosters restore protection against infection. Of the monoclonals, pretty much no activity except for sotrovimab of the FDA authorized monoclonals. And we don't have any data from remdesivir, molnupiravir, or Paxlovid, but they should be effective. A very large insurance company in South Africa confirms this data. And one of the things that I want to mention about their data is that hospitalizations appear to be going up in children. And that's something to be aware that, although these numbers are smaller, the data suggests that children have about a 20% higher risk of hospitalization than with previous variants. And I'm a little concerned about that. So a summary that was put together by Eric Topol in Twitter, I think summarizes this. The cases doubling 2 or 3 days, a 3-fold higher risk of transmission than Delta in households. Immunity from vaccination drops to 35% after 2 doses, but you can get a boost that gets you up to 75%. We may see a lot more cases, maybe less severe disease, but the numbers were still going to be high and hospitals would likely be in trouble. There's immune escape and reinfection and prior infection doesn't protect you. So we need to get vaccinated. If we haven't, we need to get boosted if we've been vaccinated. And I think really important, we need to get mentally prepared to act more cautiously if once Omicron proves to be, as it is, more infectious, immune evasive, or both. I think we need to tell people to follow the science because a lot more is going to become clear. And CDC summarized it in this MMWR today with this data and saying, get boosted, increase the detection, et cetera. Well, Omicron could lead to a surge in the winter, what CDC says. In Twitter, Eric Topol corrected and said Omicron will lead to a surge in the winter, and I think we need to be ready for that. But I remind people that forget about Omicron. Delta is our problem right now. We have over 55,000 people hospitalized, and the numbers are going up. And yes, Bob told us in Twitter this morning that he's really worried about people saying, this is less severe and therefore don't need to be worried about. And I'll show you this data looking at hospital admissions from COVID and compare the UK, which is having an increase in Omicron, but their hospitalizations are nowhere ours. Look at the US where we are on hospitalizations. This is our Delta wave. So superimpose on that Omicron and we may really be in big trouble. And I will end by getting you to read this article in The Atlantic today by Ed Young, who says, America can't beat Omicron one booster at a time. We weren't prepared for any of the surges, and we're not prepared now for the Omicron arrival. And will Omicron overwhelm the US healthcare system? And, he says the question is mute because the system is already overwhelmed. So I think the prognosis for this winter is very concerning, and I'll be happy for us to have a discussion about what do we think and what should we do if there's anything we can do both locally as a health system and as a nation. And with that, Bob, I'll end and let's have a discussion.
Carlos, thank you. That was masterful. That's a lot of information and very beautifully presented. Let's go ahead and bring on Rachel and Paul. There we are. Great. Let me start by just asking both of you to react to what you just heard. Obviously, I assume you know much of it, but hearing it in that fire hose of information as you think about your practice and your patients, how is your thinking about what Omicron means? How has it evolved in the last week or two? Maybe start with Rachel.
I think what is most striking for me is just the rapidity of spread and that very vertical epidemic curve. I think we were always concerned that something like this would happen, but this is beyond anything that I would have thought in terms of the doubling time of the number of infections and just how quickly things can change. So I think that's really, over the last few days, as this information has become more available and we've seen that the case infection rates go up in Denmark and the UK and seen what's happened in South Africa, that's really what I take away.
Yeah. Paul, how about you?
Yeah, it's been a really remarkable 3 to 4 week period. We have this excitement about nirmatrelvir, which is the Paxlovid generic name. We had the excitement about the AstraZeneca pre-exposure prophylaxis, which would, people who are immunocompromised, some of them have been living in terror because they can't respond to the vaccines. So we have that on one side. And then on the other side, we have Omicron, which really feels like it's setting us back. I do think there is, even among people who are generally pretty pessimistic, there is some thought that this is kind of the pathway to endemicity faster. that with a highly transmissible virus and a fair amount of immunity already in society, this is probably the way it's going to go. Who knows? I mean, I've stopped making predictions about this, except to say that I predict we'll have a lot of Omicron in the United States very soon.
Yeah, when I get asked that all the time. Sort of, are we moving from pandemic to epidemic? And that's a bit of shorthand that I think the ID and public health world is very familiar with, and like regular people are not. So what does that mean when you say pathway to endemicity? What does that mean in terms of real life and the way you're able to live your life?
Well, one of the really helpful things that one of my colleagues, Scott Dryden-Peterson, does each week is he summarizes the data for us in Boston, and he shows the number of people hospitalized with COVID, and then he compares it to a typical flu season at its peak, and we're way above that still. So since that's the case, we can't possibly say we're at a comfortable endemic level yet, but we might be heading there. That's really, if you're comparable to what you normally are in a winter respiratory virus season, then you're kind of heading towards endemic levels, but we're way above that. Our hospitals, like all around the country, I'm sure it's true in Atlanta and San Francisco, are jammed, and they're jammed because there's COVID plus everything else.
Yeah. We're not very jammed COVID wise, at least in San Francisco yet, and we've done very well. But obviously, that could change very quickly. Looking at these data, Carlos.
Yeah, I mean, we're not jammed with COVID in Atlanta, but we're jammed because of everything else. And I think one of the questions that I would have for everybody is, it's time that we stop focusing on number of cases. I mean, at the end of the day, is it, infections were useful at the beginning, but now we have infections in the setting of a highly or a significantly immunized population in the setting of a significantly immune population because they've had infection in the past. And do we need to focus the metrics on something different, hospitalizations, mortality, and other things rather than cases? Because is cases a good enough proxy of what's happening?
Yeah, it's a point that's being actively debated. Monica Gandhi and a colleague had an editorial in the New York Times this week arguing that point, that it's time to focus more on hospitalizations and cases.
Can I take the controversy?
Yeah, go ahead, Paul, to give it a shot.
I mean, I am married to a pediatrician. The cases in her practice are, as you know, most of them are mild, but they're enormously disruptive. And they cause all kinds of problems with school, with work. And some of the kids do get sick. So I think we're still, until we are a little bit further along, I'm still in the, let's count the cases. Emergency room visits for COVID-related illness is a very good metric. We're way up compared to where we were.
I agree. I think that's a really good metric, actually.
Yeah.
It's a little bit like what we do in influenza with ILI visits, right?
Yeah.
We don't look at influenza. We look at influenza visits.
Yeah, I guess I'm also a little bit, when I hear that argument, I'm still trying to decide whether I eat in an indoor restaurant. And I kind of want to know what is the probability that the waiter or the person at the next table has COVID, in part because I just still don't want to get it. Maybe that's old fashioned, but I'd still prefer not to get it. I don't understand long COVID yet in Omicron, all that kind of stuff. So I still think cases are useful until there's more of a proven dissociation between cases and bad stuff. Maybe that'll happen with the Pfizer drug when that rolls out. Maybe it'll happen because Omicron proves to be more mild, but I'm not quite there yet. Rachel, where are you on the cases versus hospitalization metric?
I completely agree. I think we're not there yet. We still don't even know how hospitalizations will pan out with this. It's still very early. We know that hospitalizations and deaths lag. And also, I think the long COVID point is well taken. We don't know what the long-term effects of milder infection are going to be.
Yeah. So when we think about less severe, I noticed, Carlos, you said that we don't think it's more severe, but didn't put much of a nickel down on what seems to be the party line, which is it's significantly less severe. And you seem to feel like there's so many confounders, it's too early to go to the bank on that. So explain that a little bit, and I'd love to hear the other two reaction to that issue.
I want to see, first of all, I think it may be a little too early. As you and I know, it takes a little bit to go from cases to hospitalizations and severe illness, 2 to 3 weeks. So we should start knowing soon. But I also, the way it's happening, when I talk to colleagues in South Africa, their average age of the population is young. And most of them had either been, for example, I spoke to our friend Slim Abdul Karim. Everybody in his unit is immunized. About 70% of people have been infected, but their average age is 35 years old. So it's a very different population. It's like talking about a college, right? I want to see Omicron go through a nursing home or go through a long-term care facility, and then we can talk about whether it's more severe or not. And I'm worried that, if you talk to people at CDC, booster in our nursing homes in our country is actually very low. And I want to see what happens if we don't boost nursing homes quickly. We may see significant outbreaks in our nursing homes, and it may not be a mild disease. So I'm not ready to say this is more mild than other viruses.
Where do you stand on that based on your take of the evidence and what you've seen so far, Paul?
It's very hard to disentangle prior immunity from these data. And, if you look, people who've been infected before and people who've been vaccinated, that's prior immunity. They tend to get breakthrough cases that are less severe, but the intrinsic virulence of SARS-CoV-2 probably remains with this virus. So an unimmune person encountering Omicron is probably just as likely to get sick as an unimmune person encountering the original Wuhan strain. So I'm not ready to buy that it's less severe. I've heard many people say, it's got so many mutations, it's got to do something to its pathogenicity, but that's actually wishful thinking.
Right.
It's not actually based in any science that I know of. I hope it's true. I don't think it is.
Right.
Though.
I think, this is one where your brain wants it to be true so much that
Yes.
it sets us up for a bias. And I think it's also, if it's less severe, at least the hospitalization data from South Africa said, maybe 30% lower hospitalization, but if it's twice or three times as transmissible, the math works out badly there. I think. Rachel, what's your take on all this?
Yeah, I think if we have double the amount of cases, particularly in a short period of time, that 30% decrease in hospitalization will be overwhelmed by the sheer number of cases. So we have to see.
Yeah. In terms of booster strategy, well, let me ask one more question. I haven't seen this piece of data around. It would be very useful. Paul just made the point that he's most worried, in addition to immunocompromised people, most worried about folks who have neither been vaccinated nor infected. How many of those people do you think there are at this point?
When you do seroprevalence studies around the country, I know that antibody is not a perfect measure of this, but there's a substantial fraction of the US population that has not been vaccinated and has not caught COVID yet. That may not be true in all regions. Obviously, certain parts of the country, like for example, here in Boston, there are certain very densely populated neighborhoods that had very high seropositivity rates, but that's not the rule. And so it does concern me. I can't give you a precise number, but it's our immunity wall is not as high as Great Britain's. They like to show that off.
Yeah.
Well, South Africa had, from prior waves and their data from their blood banks, again, blood banks is not a perfect proxy, but 65-70% of the population had evidence of prior immunity, whether it's through vaccination or through natural infection. Yeah.
And it still rolled through there pretty badly.
What I worry in our country is we are about 60% vaccinated. And let's say the other 40%, some of them have, immunity from prior infection. But if immunity from prior infection doesn't protect you against Omicron, you got 40% of people in our country that are susceptible.
Yeah.
Even if you got everybody else immunized, that is a lot of people that have no immunity against this virus.
Right. And then you take the people who got their 2 shots a year ago and, yes, they're partly protected, I guess. Do you think, should the CDC announce today that the definition of fully vaccinated is no longer 2 shots? Would that be, you like that? Because I see that, in the newspaper all the time, this percentage of the population is fully vaccinated.
Well, they think the J&J vaccine is still considered full vaccination, and almost every study shows its effectiveness is lower.
Yeah.
Even a recent study in this flood of preprints that showed up about Omicron showed that the antibody levels generated by boosting the J&J vaccine with one mRNA vaccine afterwards were substantially lower than the third boosting shot for the mRNA vaccine. So, it's looking like if I had been a person who had the J&J vaccine originally, I would go for a third shot. I would like to match up the number of shots with 2 additional mRNA vaccines.
How long would you wait after your first booster?
I don't think there's any precise amount of time, but and I wish there were data on this. Maybe Carlos or Rachel, you know it, but I would, a few months later, go get your third shot.
Yeah, yeah. Rachel, as you were dealing with people in the clinic setting, and I'm sure you get a ton of questions like this, have you been successful in convincing people to get vaccinated? And if so, what's your strategy? And has it changed at all in the last month? Is this sort of creating a level of concern that's different than over the past year?
I think that, well, first of all, we haven't actually had a lot of unvaccinated patients practicing in San Francisco, at least with my primary care practice, which I recently left, but almost all my patients were vaccinated. So that was great. I think in the ID clinic, we have more unvaccinated patients. Many are very difficult to convince, but I think with Delta, that really changed a lot of people's minds. And I imagine with Omicron, it will change more. And I think that, just pointing out how many people have been vaccinated is reassuring to people.
Mm-hmm.
But there are some people who are very difficult to convince.
Yeah. Paul or Carlos, have you come up with any techniques or ways of framing the data that seem to be working, or just frustrated? And at this point, if you're not vaccinated, it seems like there's not much we can do. Carlos, why don't you take that?
I think we still, it's almost like one person at a time, and many of them, it's a personal issue. It's about somebody I recently talked to into getting vaccines were 2 young men, 2 African-American men in their 30s. And it was basically, their mom saying, if you want to come to Thanksgiving, you need to be vaccinated. Otherwise, you're not coming. And they wanted to be with mom, and that's why they got vaccinated. And, the reason they hadn't been vaccinated is because they had heard this thing that it produces infertility and sterility. So a lot of misinformation is leading some people not to get vaccinated. Many young people also are saying, well, this is mild. Why should I care about it? And you have to really tell them, well, you care when you go home and see grandma, and that's when you can be in trouble, right? No. So trying to find a personal reason for somebody and a trusted messenger, I think, continues to be the way to get this across.
Yeah. Paul, how about you?
Yeah, again, vaccine and vaccine hesitancy is such a part of my dinner table discussion with my pediatrician wife. This is a very, this existed before COVID, and it still exists. I totally agree that getting misinformation is one reason that people don't get vaccinated. We did a clinical study that paid a small amount for participation, and some of our holdouts ended up, just because they wanted the $100 stipend, got vaccinated. I don't know why that was so beneficial to them. Not all of them needed the money, but it was just what it took. There are all kinds of reasons why people make decisions, and I think it is frustrating sometimes.
Yeah, sure is. Let me add a few practical questions. Paul already answered the J&J question, which comes up all the time. Rachel, what do you tell people who got a first Pfizer or their 2 shots with Pfizer and are asking about switching to Moderna and vice versa?
I think get whatever shot you can. At this point, I think they're probably pretty equivalent. And right now, one of the things that we're coming across is that wait times to get booster vaccines are long. Many of my patients are telling me they can't get an appointment until the 2nd week of January. So I think whichever mRNA vaccine you can get that one.
Yeah, I agree, Rachel. But I think when you said get whatever you can, get whatever mRNA vaccine.
Yes.
Are we, Carlos, are we done with J&J as a primary vaccine? Should we just get rid of it?
I'm done with J&J as a primary vaccine. I think the mRNA vaccines, are the things we need to be using. I would not recommend right now a J&J vaccine. I think a question we get a lot, and there's not a lot of data, and I would love to hear is, a lot of people globally have been vaccinated with AstraZeneca based on the co-boost study. What are you recommending when somebody travels from Europe, comes here, or from other country and says, I want to get a booster, what do I do?
Yeah, what do you tell them?
Well, I tell them to get an mRNA vaccine, but I tell you, if you go to your CVS and say, I'm here for a booster for an mRNA and I got AstraZeneca, they tell you, oh, that's not in the recommendations from CDC and therefore we cannot give you a booster. So you have to tell those people, you need to lie. You need to go and say you're getting your vaccination for the first time. I mean, it's very unfortunate that CDC has yet to come out with recommendations when we live in a global community.
Yeah, yeah. Paul, any comments on that?
No, I agree. I mean, I've recommended several people who've gotten the AstraZeneca vaccine get mRNA vaccination, and they get signed up for the 2-dose series, because that's really what they're saying. Yeah, I mean, I do feel like the J&J vaccine was really of its time. You know, we were looking for any glimpse that we could get out of this mess, and it was an alternative vaccine strategy. It had some logistical advantages, but the data consistently showed it was less effective, and we stuck with it for way too long. I think that's unfortunate. And then I hear the CDC's looking again at its thrombosis syndrome. So
it's actually the ACIP meeting was yesterday and today. They're having a vote on it today, I think.
So is it possible they'll withdraw the approval for it?
I don't think so. I mean, I really don't think so.
Okay.
But, you know, it's not only in the US. I mean, globally, I was hearing in South Africa, you know, they received a big donation of J&J from the US, and South Africa said, thank you very much, send it somewhere else. We don't want it.
Interesting. Yeah, I love that Paul saying of its time. It's so 2020, that vaccine, right? I've heard people say, I want to not get my booster now because I think I want to wait for the rejiggered Omicron vaccine booster. What do you think about that strategy? Maybe Rachel, start with you.
I think we know from the data that we have available that the booster shot is actually quite effective at boosting immunity. Perhaps not as high as for the prior variants, but still quite good. I don't even know that they're going to introduce variant-specific boosters, depending on how the data plays out, but it's certainly not going to be for a long time. So I would certainly advise for people just to go ahead and get it now.
Okay, good. I assume that's your. Go ahead, Paul.
One reason to advise that strategy is because the way that these surges they come in these periods that last a couple of months, and that's probably how long we'd have to wait before we have an Omicron specific booster. And there may be very low disease activity. Remember last winter, which was dreadful, the activity started to wind down by the end of January. And even though it was still winter, their case numbers dropped substantially before the end of the winter. I hope that is what happens this time, because, you know, even though it's a seasonal virus, it doesn't have to last the whole season.
Yeah. And is there evidence emerging, maybe Carlos, is there evidence emerging that this thing is going to spike high and come down fast the way it did in India? Actually, prior variants, obviously, but just the nature of what we've learned about Omicron, is that what we can expect, a couple of early bad months and then improvements?
Well, that's what I hear. As you know, CDC has now has a sort of a think tank, a center for pandemic sort of preparedness, that they're looking at this, and Mark Lipschitz it's actually running that. And what Mark presented the other day was that this Omicron is probably going to peak in like the second week of January and then come down, and by the end of February will be gone from our country. So it looks like it's going to, you know, peak quickly and come down quickly. We'll see what happens, but that's what at least their predictions, their modeling suggests, based on the you know, the rapid increase in number of transmission and cases.
And when that happens, do we understand, is it just that so many people have gotten infected that now the immunity wall is higher than it was, or is there some other hand waving that we don't understand about why these things come up and come down so fast?
I think there's human behavior, right? I mean, people all of a sudden start not going to restaurants and not wearing masks and being a little more careful. And I think it's just, and getting more people get vaccinated. I mean, I can tell you right now, just the scare of Omicron has increased the number of people ready to get vaccinated and getting boosted, which I think is going to change what the susceptible population is. So I think this is very dynamic. And when you talk to, again, the other day I was talking to Chris Murray from Institute for Healthcare Metrics and Evaluation, and he was saying, you know, in all the modeling, what they really have not been able to model effectively is behavior, right? Because you can model the virus, you can model the transmission, but you can't model the behavior.
Yeah, yeah. So does that argue that even though many people and politicians and health leaders are, quote, over it, the next couple of months people really should hunker down, that we're in a period of high risk that's going to last for a period of time and then probably go away? Paul, is that how you're thinking about this?
Well, you know, infectious disease doctors probably are not representative of the behavior that the entire population is going to take. And I would certainly say that's true for the author of that piece in The Atlantic that got so widely criticized by us.
Mhm.
But you know, I confess, you know, here in Boston, and you know, I'm the son of a food journalist. I have not dined inside in a restaurant since the spring of 2020. I miss it greatly. And I'm going to put that off until, you know, case numbers drop some more. I mean, unfortunately, we had case numbers that were very low here in the early part of the summer. And then Delta kind of ruined that. And it showed that, you know what, we're still a very susceptible population. So you can get together with your friends in small groups, but in crowded areas, that super spreader event in Norway is like a perfect example of how you can disseminate COVID very quickly. You put a bunch of people together in a place that probably has poor ventilation because it's wintertime. You have them talking loudly at each other all night without a mask. I mean, they're basically enjoying themselves. Of course, it's going to lead to lots of spread. To limit the size of the gatherings makes a lot of sense when there's a lot of transmission.
You know, and I think one thing that is pretty clear now, Paul, it was clear with Delta, but I think it's even more clear with Omicron, is this is airborne, right? I mean, we made a lot of distinctions between, you know, respiratory particles versus airborne. It's not really if or, you know, it's a combination of both, but this clearly is airborne and can be transmitted airborne. And I think there's some nice data that I saw the other day saying that I didn't put it in my presentation, but that it can remain in the air for up to an hour or two after you leave the room. So, you know, you could potentially, again, in that restaurant, you could go there, you can go to a room later and be infected. You know, question that is in the chat, and I think worth for us to ask to answer is that, you know, you mentioned not eating outside. What are we going to do for Christmas and New Year's? And I'll be very curious to hear what people are doing for Christmas and New Year's.
Yeah. So, I mean, so Paul, you won't eat inside in a restaurant. Will you eat outside?
Yeah. And, you know, the airborne viruses get diluted by ventilation so efficiently outside. I've eaten outside in many restaurants. It's just very hard to do in Boston in the wintertime.
Yeah, still okay out here. Let's talk for a minute. I'm going to get to sort of holiday plans, and those are the dominant questions that are coming up. In terms of the oral antivirals, how excited are you about the Pfizer drug? Maybe start with Rachel, and you know, sort of how much of a game changer do you think it will be? This is the Paxlovid.
I think it's huge. I think that it will be a completely paradigm shifting development. My concerns about it are just the infrastructure and getting it to patients in a soon enough time frame. So I think that's going to be the major challenge of the coming months.
Mm-hmm. And why is it a game changer, and how do you expect to use it? So where does it fit in a world with monoclonals? Are you using it instead of or with, or how are you thinking? And which patients would get it and not get it, particularly in the short term, when if it's available, it may have a limited supply in the short term?
Yeah, so I think it'll be targeted to high risk patients. And I think, you know, I'm not sure which I would choose if I had access to both a monoclonal antibody or Paxlovid, but the truth of the matter is it's just much easier to get an oral medication and to get it to somebody quickly. When we refer somebody for monoclonal antibody, it usually takes several days to set up. Many of my patients live far away. And so if we can get a good distribution system going, then we'll be able to get people treatments that prevent hospitalization, prevent death in the outpatient setting, hopefully quickly, and that will hopefully make a huge dent.
Yeah, Paul, what are your thoughts about it?
I mean, in addition to agreeing with what Rachel said, remember this antiviral lowers viral load tenfold. You know, this might make people less contagious quickly, and that's very exciting also. I think it's a terrific advance. I was all giddy about it until Omicron hit. I mean, it was really exciting to see the data, because in the second press release, the full analysis of the high risk study was just as robust as in the first analysis. That's contrasting with the molnupiravir. And then they also presented data on the standard risk patients. And that group also had a reduction in risk of hospitalization, which I thought was very notable. So I'm thrilled that we have an antiviral that has both clinical benefits as well as antiviral benefits.
So just to be clear, you said you were giddy until Omicron hit. When Omicron hit, it should make you giddier, right? Because it actually will work against Omicron.
Really, what I meant was actually they did do some in vitro analyses, and they show that they should be active against Omicron. What I meant is that Omicron put a damper in my otherwise, cheerful mood.
Just took away your giddiness in general, but
Exactly.
if anything, the
Oh, yeah.
value of this may actually go up
Absolutely.
in an Omicron world, right?
Absolutely. It not only does the value of this go up, but I'm going to actually bring up something very surprising, which is that remdesivir, which has a very checkered history on the inpatient side, looks best when it's given to outpatients early in disease. And, in some ways, with all of the concerns about immune escape for monoclonal antibodies with Omicron, that could be something that would be very easy to do for some infusion company. Give 3 doses of remdesivir. You don't need any observation time. It goes in over 15 to 30 minutes. It prevented hospitalization, 90% reduction in hospitalization. So if we do have supply issues with Paxlovid, I would hope that we'd be able to try to gear up to give remdesivir as outpatients. Nobody I know has been doing it, but unless some of you have, but I don't know of anybody who has so far.
Yeah. Carlos, any comments about the new drug?
I think I'm very excited about having oral agents. I mean, as Rachel said, the issue with, monoclonals or with remdesivir is the setup.
Oh, yeah.
The IV, you have to do this, you have to do that. And, whether you like it or not, we're all struggling with having enough nurses. And when we had the Delta surge, my CEO of the hospital said, look, I have nurses for taking care of patients in the inpatient or doing the infusion. We can't do both, right? We need to figure out a way to do this. So it's nice to have something oral. I think one issue that we all need to think about, yes, I was talking to a colleague from University of Miami, and they're seeing a surge already in Omicron in Miami. But they have Delta, and when people show up in the ER, you don't know what they have, right? Mm-hmm. And you give them monoclonal then, and if they have Omicron, it's not going to work. So at some point in time, we have both epidemics happening at the same time, and know that some drugs are not going to work versus others are. And I think we're having both at the same time. I'd rather go remdesivir, or I'd rather go a Paxlovid or something else rather than monoclonal that may not work in that individual if you give it.
And do you think, and this brings up the question, do you think that's what we're destined to have for a while, both epidemics at the same time, or do you think Omicron just rapidly becomes the virus that we're confronting?
I don't know, because again, we're having a lot of Delta right now. So it's going to take a while for Omicron to take over. I think we may be having like a 50-50 or something like that. Some places that have little Delta right now may see a lot of Omicron, but in Michigan or in Minnesota and other places that have a lot of Delta right now, I think it's going to take some time for Omicron to take over. They may be having both at the same time. Mm-hmm. The issue with these drugs, is we got to get testing, we got to get people diagnosed, and we got to get them on therapy within 5 days. This is no different than with flu and with oseltamivir, right? You got to get people on therapy very quickly. And again, our system is clunky. I mean, we have trouble doing this kinds of things. I mean, this should be a no-brainer. Get tested at home, get a sample, here's your prescription, be done, right?
Yeah, no, it's not non-trivial to figure out all the moving parts here, and particularly if there's a shortage in the short term and everybody's going to want it, and even people at lower risk are going to want it, and it's going to be messy. Paul?
One thing is that I saw someone was quoted saying, oh, the person's going to need to come in to see a doctor and before you get their prescription. And that's definitely not the model. I mean, we've known for influenza drugs for years that you can make a clinical diagnosis of influenza. You don't necessarily, during the peak flu season, need to bring someone in to confirm the diagnosis, and you could treat them with oseltamivir without them coming in at all. And I strongly suspect what we'll be doing with this is people will be doing home tests. And if the home test is positive, they'll get their prescription for antiviral treatment, and they'll never have to come into that and interface with the healthcare system.
Yeah, and actually, the last thing you want to do is bring them in if you can possibly avoid it. Let's turn to a lot of questions about kind of practical issues, and I'm sure the questions you all are getting. Holiday get-togethers that I've been planning on and looking forward to, and now Omicron, and should I cancel flying to visit grandma in Florida? Should I cancel? I was planning on going to Europe. Should I eat indoors? All that kind of stuff. So, Rachel, why don't you either summarize what you're telling people, or maybe if you're comfortable summarizing what you are doing yourself and with telling family members.
Sure. So I can start with in general. So I think the travel and the gathering decision kind of is an individualized decision based on your personal risk, the risk of the people around you, your tolerance for risk. I think that certain things I probably wouldn't recommend doing, like going to Europe right now. First of all, Omicron is surging there, and you need a negative test to get back into the United States. So I think there's a very practical issue. You may not be able to come back until quarantine. And then in terms of holiday plans, I think it depends on the size of the holiday. It depends, again, on the risk of the people around you. I probably wouldn't myself be too excited about flying to see my 97-year-old grandmother. But for myself personally, my family gathering is going to be very small. Last year we did it outside, but there are only 5 of us. So we're going to continue as usual, but we'll do rapid tests before which are very readily available.
And would you feel comfortable visiting 97-year-old grandma, God bless her, and do a rapid test before you came and saw her? Would that make you feel like this is a pretty safe thing to do?
That's a tough one, and actually one that I need to decide, because I was supposed to see my 97-year-old grandma in a couple weeks.
Mm-hmm.
I think in my situation, I would with a test before I have a booster. She's been fully vaccinated. And, I get to see her very rarely. So I would wear a mask, she would wear a mask, and that would be the decision that I would make for my.
So even if she's fully boosted, you're boosted, you do a rapid test in the morning, you're negative, you would still not come and sit down with her without both of you wearing masks?
She's not boosted.
She's not boosted, okay.
She was a late comer to the COVID vaccines, which is.
Let's say she was.
Yeah, let's say. Personally, I would still be nervous. Yeah. But I think that's probably overly cautious.
Yeah. Well, you're an ID doc. That's who you are. Paul, what do you take us through the various scenarios? And with your wife, a pediatrician, maybe layer in, you got young kids.
Yeah, I've got young kids and interacting with my wife, but I don't have young kids. I have adult kids.
Yes, me too.
And the adult kids are we know adult kids are the highest risk for getting COVID. Adults, young adults, teens and young adults, they're the ones who are socialized the most. And that's been the case, from the beginning of the pandemic. And one of the things about the vaccines that's been so liberating is that we realized that we could see them relatively safely. And that's also been one of the nice things about the home tests. Now, the home tests are not perfect. We have no illusions about them. But just to sort of take it back to the elderly parent, I have 2 elderly parents in New York City. And we've made the decision that with a negative rapid test right before seeing them, that we're just going to do that. And there's this actuarial cost of delaying too long that I worry about, that we're just not going to get a chance to see them ever. And so for some time now, that's how we've been doing it. And in fact, we're visiting them this weekend. So the travel, you're driving or flying? We're taking the train.
Train, okay. So
and then the train, they say their ventilation is very good and as good as the flights. Well, who knows? And then we're doing rapid tests right before we're seeing them. And it's important that people who are using rapid tests not do them that morning or the day before. They should be done as close to the actual visit as possible. Wow. And of course, we wouldn't go at all if we had any respiratory symptoms. I mean, this is critical. People should not use the rapid tests when they have a respiratory tract infection as a way of reassuring themselves falsely that they may not have COVID. I've heard that mistake made numerous times.
Really? I guess I probably have made that mistake. I wake up and if I have a little scratchy throat, I'll test myself. I'm negative. I feel pretty good. But
you should feel better. The likelihood that you don't have COVID is decreased, but by no means does it rule COVID out.
Right. But doesn't it come close to ruling out that I'm going to infect grandma that day?
I would not trust it. I would not go visit grandma with a respiratory tract infection in the COVID-19 era, period. Okay. In fact, remember, grandma previously was always vulnerable to getting RSV and rhinovirus and metapneumovirus and those things.
If you feel crummy, you have something, and you want to give that to grandma. Exactly. All right, you've gotten your test an hour before you saw grandma. Right. You've all been boosted. You wear a mask when you see her? Do you hug her or not? No. So you're comfortable, rapid test that day or right before the encounter and everybody's boosted, you act normally, no distancing, no nothing. Maybe you keep a window open, but that's it.
Yep, that's correct.
Carlos, what do you think?
And that's what I do with our friends too when they come over for dinner.
Yeah.
I agree with Paul. we're going to get together with family. We have, young adult kids, and there'll be some unvaccinated kids under 5, 2 of them. And there's, my mother who's 87 years old. She's vaccinated, but she's only going to get her booster this week. So she's really not going to be boosted in time for Christmas. No symptoms. If you have any symptoms, you don't come in. Everybody else is vaccinated. Most people are boosted, not everybody. And my contribution to the dinner is having the rapid test. I bring the rapid test, and as people are walking in, they're getting their rapid test. And, this is part of the procedure of coming in. I personally, I have been flying. I test myself, a day before I fly. I fly. I can tell you, I've been working with Delta throughout this process, and they've really done an incredible job of changing
that's the Delta airline, not the Delta virus.
Not the Delta virus, and changing the filters and the ventilation. I've learned a lot about plane ventilation. I think the plane is fine. The problem is when you are boarding and deboarding. That's when you have a lot of crowding and a lot of things happen. And then, quite frankly, what you do when you get there. So, I test myself before I fly. And I keep a mask on, and I test myself 48 hours after I fly as a way, again, to make sure that I'm negative. And I've done that pretty routinely, and so far have not gotten infected during a trip.
And your family gathering, masks or no masks?
Once everybody's test negative and everybody's vaccinated and boosted, no mask. But again, the testing is happening at entry. And if people want 2 tests, again, I remind people, for example, the Binax now comes in package of 2. It's not to test 2 people. It's you can test yourself 24 hours before and at the very moment, because 2 tests increase the positive predictive value if you do 2 tests sequentially.
Well, it sounds pretty safe. So my son and daughter live in Atlanta. They'll be over for dinner in a couple of days. So thank you. We're coming to the end, and I'll give you each a chance for any final comments and how you're sort of processing all this and thinking about the next several months, and sort of what you want to leave the audience with. Paul, do you want to start?
Yeah, I just want to mention something about the AstraZeneca pre-exposure prophylaxis, because as I mentioned before, I was so excited about that for my patients who are immunocompromised, who have lived in terror of this virus for so long. And right now, the data are unclear whether Omicron will make the antibody combination inactive. So stay tuned. I've seen confident reports that Omicron evades AstraZeneca's compound, and I've seen the opposite. And so we'll see. I mean, I don't think we know yet. So
when you talk to those patients, transplant patients on immunosuppressives, what do you tell them about how to live their lives?
So some of them have been totally housebound, and I say very important that you be able to go outside, feel safe going outside, unless you're having like a face-to-face conversation with someone at close quarters. Outdoor activities are quite safe. Mm-hmm. So it's really to get them out of that hermit existence. And then the other thing is to have people who visit them to do rapid testing before they come. Yeah,
thank you. Rachel, anything you want to leave folks with?
I think just that we will see how this will unfold. I think the next couple of weeks will be very informative.
Yeah. Carlos.
Well, I think I tell people a couple of things. I say, while the current situation continues to be serious, we're in a much better place now than we were a year ago. I think that vaccines remain highly active in preventing severe disease, hospitalization, and death. You need to get vaccinated if you haven't, and you need to get boosted. I think masking indoors continues to be important, and I tell people, especially our colleagues in healthcare, we need a lot of resilience, and I know we're running very low on resilience, but at this time we need to do whatever we can to cheer people and to help people get through this process, because people in healthcare we're all very tired, people are exhausted, and I think we're still in for some very tough weeks and months ahead, and we need to take care of each other.
Yeah, definitely. Support group for each other.
Yeah. Well, thank you, all three of you, for a really informative discussion in a very rapidly evolving world. Up until really the last couple of days, I've been telling people for their holiday plans not to think that much about Omicron. That probably is wrong. I mean, it feels like it is here, and it's an important player. So I know we're all tired of this, but it's important to still be thoughtful and careful, and you've given people some terrific advice. So thank you all. Have a fantastic holiday to all of you and to all of our audience, and we'll see you back for Grand Rounds in a few weeks, 3 weeks, January 6th. Thank you to our three speakers. Thank you to all of our folks that put this on each week so flawlessly. and be well and happy holidays.